Welcome to the AP-CTO Club session in TCTAP 2022. I want to thank my co-moderator, Dr. Paul Gao from Taiwan, and also Dr. Tsuzikani, who's been masterminding this session behind us. I would like to introduce you to our panel, Dr. Kao Chen from Hong Kong, Dr. Yangzu Zhang, Feng Yu Gao, and Neha Lee from Korea, and Dr. Wataru Nagamatsu from Japan, who are our co-panelists. And I would like to thank TCTAP for this opportunity for this session in AP-CTO Club here. So I'll ask my co-moderator to introduce the session speakers from here on.
Sure. Okay, Eugene, and everyone on the screen. It's really my pleasure to be able to join this session in the TCTAP 2022. So the session is AP-CTO themed focus session. So our first speaker would be none other but Eugene. Eugene Wu is one of our active contributor of the AP-CTO Club, and his topic tonight will be the new global CTO crossing algorithm. Eugene, please.
This is the Global CTO Club algorithm, which was published in JAC August last year. And I'm, along with many others, the authors of this work. These are my disclosures. So over the past 10 to 15 years, there's been improvement in the success rate of CTO PCI from, if you look at the registries from about 10, 15 years ago, 50 to 70%, to now, the last 10 years or so, the success rate has gone up to about 85 to 94%. Now, undoubtedly, part of this is due to the technological advances, better microcatheters, better wires, but also is due to the adoption of an algorithmic approach to CTO PCI. When we talk about CTO PCI algorithm, of course, we have to begin with the hybrid algorithm, which is published by my good friend Manos Blakis in 2012. Subsequently, in 2017, Scott Harding in our group published the AP-CTO Club algorithm. The year after that, 2018, I published along with the AP-CTO group the retrograde algorithm. And the same year, Zhenbo Ji in China produced the China CTO Club algorithm, which has many similarities to the AP-CTO algorithm, as you will see later on. This is followed in 2019 by numerous algorithms, including the Japanese algorithm by Tanaka et al. And the Euro CTO Club consensus document by Freddy Lassi. This is the four of the algorithms that you can see, and you can see there are some similarities as well as some differences between these algorithms. Now, in our paper, we actually have a very nice table, which is produced by Manos, listing out all the similarities and differences between the different algorithms. Across the board, there's some broad similarities. All the algorithm recommends dual angiography and also careful analysis of the angiogram. All of them have retrograde option, and all of them use retrograde option to deal with poor distal vessel or bifurcation in the distal cap. In terms of dealing with the problem of proximal cap ambiguity, the hybrid uses retrograde, Asia Pacific uses Ibis and retrograde, EuroCTO use retrograde, Ibis, and move the cap, and that seems to be the moving trend. And the global also uses Ibis, retrograde, and move the cap, but there's quite specific method of doing this in the global algorithm, which I'll explain later on. Single antegrade wiring strategy is used only based on length alone in hybrid. So if the length is longer than 20 millimeters, they will do ADR. In Asia Pacific, it's pretty much on the opposite end of the spectrum, where we will only use ADR if there's additional reasons like coarse ambiguity, tortuosity, or heavy calcification. And most of the other algorithms fall between the two. A retrograde is very similar, really. It's used mainly to overcome the problem of ambiguous proximal cap or poor distal vessel quality. And whether you do reverse cut or single retrograde wiring is mainly dependent on length across the board in different algorithms. All the algorithms have reverse cut, but AP-CTO have a specific preference to contemporary reverse cut. And all of them recommend us to change strategy if we're stuck. And only the Euro CTO Club have an investment strategy, which is also present in the Global CTO Club. When to stop the procedure for the hybrid is mainly radiation. For AP-CTO is radiation, contrast, and procedural time. In the global, you'll see we added other factors, which we'll discuss later on. So this paper was drafted by 4 main authors, the first 4 authors, and with the initial document, it was sent to 125 authors in 50 countries who contributed over 140 comments, resulting in the final paper. And I'd like to take this chance to thank all my co-authors listed here. This is the central illustration from the paper. You can see it's an algorithm similar to the different algorithms we've seen before. The algorithm is listed in 10 points, which I'll cover briefly in this talk. Number 1, geoangiography is the cornerstone of CTO PCI and should be done after IC nitro and in conjunction with CTCA. Like all the other algorithms, careful angiographic review, focusing on proximal cap morphology, CTO length and composition, distal vessel quality, and collateral circulation is recommended. In approaching the proximal cap, we do, like all the algorithms, suggest Ibis, retrograde, and move the cap, but not in a stepwise manner, but rather based on anatomy. The principle we use in the global algorithm is anatomy dictates strategy. Yes, when we are comparing the risks, Ibis guidance has very low risk. Move the cap has a little bit higher risk, and retrograde has slightly higher risk with more periprocedural MIs than the other two. So yes, there's a stepwise increase of risk, but this stepwise increase of risk should not dictate strategy because anatomy is more important. Now, if the anatomy allows 2 strategies to be used, then of course the lower risk one should be tried first. So in the paper, there's this phrase which we're quite proud of. Instead, it says, the strategy that optimizes safety and increases the likelihood of success should be selected based on CTO anatomy. This is one of my examples. You can see a dominant OM branch with a distal circumflex CTO with complete proximal cap ambiguity. There is an OM to OM epicardial channel that's fairly tortuous and I think difficult, if not impossible, and certainly high risk. Of course, you can move the cap, but there's a good chance you're going to destroy that OM branch if you do move the cap, and you have to do block and move. So obviously, in this case, the anatomy leans us towards Ibis guidance. And you can see on the right panel here, we did Ibis guidance, and then Dulumen, Conquest 12-gram puncture, step down to XTA wire down to distal cap, re-step up to Gaia second, puncture into true lumen, and stenting with great results. Conversely, this case of an RCA CTO, there is some cap ambiguity. We don't know which direction it goes in. There are 2 branches, but neither of the branches can we see the cap clearly with Ibis. Of course, you can move the cap in this case, that will be reasonable, but there's a retrograde channel. And when we cross the septal channel, the Sion wire already goes to the cap, and it's in fact a very short CTO, a simple retrograde puncture, externalization, and stenting, and we can produce a great result. So this case, the anatomy favors retrograde, although retrograde is highest risk of the 3 methods. So number 4, approaching the distal vessel quality, poor distal vessel quality, or bifurcation in distal cap, we recommend the use of retrograde approach, but we also recommend, if there's a bifurcation in distal cap, to use Ibis checking and to use dual lumen catheter to access the side branch. We changed the term that's been used very long time, the term of retrograde collateral channel, and we've changed it to feasible retrograde options because sometimes the retrograde option is not a collateral channel. It could be an occluded or a patent vein graft or lemur graft. We recommend the use of septal channels in preference over epicardial channels because we recognize the risk of epicardial channel is a little bit higher than septal channel. Number 6, for antegrade wiring strategies, we are stuck with the length of 20 millimeters, but we also added the consideration of calcification, tortuosity, and on top of what AP Steel Club algorithm has, we have this other consideration, which is a suitable reentry zone. So you can see a beautiful zone for stingray reentry that might push you towards ADR, even if there's not much calcification or tortuosity. And you can see here in 6 below is divided into 6A and 6B. So the global algorithm allows you to go to parallel wiring or Ibis guided wiring if that's your expertise. It also allows you to go down to ADR if that's your expertise. This is a simple figure in the paper, and it basically tells you what happens when your antegrade wire fails and is in the subintimal space in A1. You can, of course, go to Stingray, A2, and do a sting into the distal true lumen. You can, of course, use parallel wire, B2, B1, with a dual lumen catheter, and wire the distal true lumen, B2. Of course, you can come retrograde, do reverse cut, C2, successfully cross, externalize, and stent it in C4. These are the options you can take. In terms of retrograde approach, number 7, the long occlusion with severe tortuosity and calcification will mean you go towards reverse cut, RDR. Like all the algorithms, recommend change and avoid being stuck in a failure mode. Point 9, investment procedure. This point was the most argued point in the whole algorithm. We spent lots and lots of emails arguing over this, and we couldn't actually get much consensus with specific types of methods. So in the end, we decided to go with the phrase, we should do investment procedures when anticipated benefits exceeds potential harm. When to stop? Like the APCO algorithm, we suggested if procedure time is longer than 3 hours, if the contrast volume is more than 3 times the estimated GFR, if the air curve is reaching past 5 gray, we should stop unless the procedure is well advanced. But beyond this, we've added several other stopping criteria. If advanced crossing strategies such as retrograde or ADR and Stingray is needed, but the operator is unfamiliar with these techniques, he should stop and get a proctor to help them. If there's also significant operator or patient fatigue, he should stop. If there's an occurrence of a serious complication, he should stop. So basically, this is a real-world algorithm. It's not designed for the master performing a live case where he must succeed. The stopping criteria allows you for a real-world operator who gets tired in the cath lab, and also if the complication happens, you don't have to win. Safety is more important. So in conclusion, CTO crossing algorithms are useful tools for optimizing the success and safety of CTO PCI. The global CTO crossing algorithm reflects the consensus of several experienced operators from multiple countries around the world and could help further improve the outcomes of these challenging procedures. This algorithm could help expand discussion, research, collaboration, and training in CTO PCI. If you want more look at the central illustration, of course, I want to thank my 3 main co-authors of this paper, Emanuel Spoulakis, Campus Mathietzi, and Tsutsikane. Last, I want to advertise an upcoming paper that is going to be submitted hopefully in April. This is the Global Consensus Recommendation on Improving the Safety of Chronic Total Occlusion Intervention. It's an addendum to this algorithm because not only do we want to teach people how to do CTO well with the algorithm, we want to make it safe. And this is the safety paper. The central illustration is there. I think on the panel there is Yangsu and Wataru, who was also co-authors, as is Paul, of course, on this paper. And so watch out for this next coming paper, which really accompanies the global CTO crossing algorithm. Thank you very much.
Thank you, Eugene. That was a wonderful overview and introduction of the global algorithm. You can see, after these years of intensive discussion, communities have actually reached these almost consensus-like algorithm. So algorithms are becoming more and more similar, and I believe it's because the algorithm now is more reasonable and more practicable than in the past. Thank you again, Eugene. Let me introduce our next speaker. Next one is Dr. Hiroaki Matsuda from Nagoya Heart Center. He's going to tell us the new CP12ST wire. I think this is a new kid on the block. So we will be very eager to understand the characteristics of this wire. Dr. Hiroaki Matsuda, please.
My name is Hiroaki Matsuda from Nagoya Heart Center. And first, I appreciate to invite me for their very good conference to CTAP 2022. My lecture explains about the new CTO guide wire, Conquest Pro 12, a sharp on tip, what is called as a CP12ST. I managed let's get started. Okay, I show the slide. Can you see that? This is COI. First introduction. What is the main factor of CTO procedure failure in the present day? Although new algorithm and the introduction of LDL device have recently contributed to the success rate for CTO PCI, but we have still experienced to fail some CTO PCI cases such as severe calcification, okay, etc. This is a strategy score the C2 that evaluates each top factors for CTO PCI. Classification is one of them, and to overcome it, CTO guide wire requires enough penetration force actually, and to solve the other issues or the factors, and such as a long CTO, they are the bidirectional approach, you know. Yeah, this page, this suggests an experiment by Asahi Intech, which evaluates wire penetration force. As you see left image, a CTO guide wire is pushed automatically at a different force, and the resistance is measured at the same time. This also is a CTO Bessel model made by Asahi Intech, and then when a guide wire cannot penetrate it, the measured resistance continues to go up because of keeping on pushing out this lateral line suggests. Conversely, at the moment that another guide wire can penetrate it, the resistance suddenly go down because the infinite stress is physically loaded after making crack. As you understand things of figure, CP12SD has the strongest penetration force in all the PCI guide wire. Now, yes, based on the above, I want to show you today's agenda. Well, now first, the feature of original CP12SD. What is the difference between the CP12SD and the original CP12? Actually, the chip has been just sharpened, as you can see. Is it just that? Yes, exactly. But the sharpened chip made it very difficult to shorten the chip, you know. And finally, the chip length was to be 1.3 millimeter, like this. In the real world practice, the 1.3 millimeter sharpened chip often produce wire diffraction. Later, I'll show you some cases we have understand why the effect is produced by the chip. But allow me to explain in detail for the time. Sorry. And why did the CP12SD develop? CP12SD has been specifically produced for LDL. Regarding the LDL, the success rate of sticking with the original LDL guide wire like this has been proven not to be so much high, reported by Dr. Habara from Toyohashi Health Center. It does not have so much strong penetration force due to the large gap between the tip and the shaft, and might be easy to prolapse due to the its low tip flexibility. To overcome these issues, several CTO guide wires have been substituted instead of it, but the result was not enough in terms of the penetration force. Yes, as you see the figure, you understand there's sufficient difference between the original LDL guide wire and the CP12SD in penetration force. Sorry, in terms of penetration force. There was the ideal situation of using CP12SD, how to use it. First, for what kind of lesion? And second, for what kind of CTO strategy? First, for what kind of lesion? It's a CTO with extreme severe calcification besides LDL. And second, for what kind of CTO strategy? Of course, LDL. And we think the Ibis Guidance is suitable to use it. Okay, first LDL case is my case. This is a LLD CTO case. You can see this angiogram that shows no interventional collateral social from the RCA, so from CT scan, and there the perhaps a double CTO. This is a very challenging case. At first, I used the guide next to, but its guide wire could not penetrate an entry of the CTO, so the change for the guide next tree. But as you can see, there remains much long length of CTO. So I changed for the strategy of with LEO. Without going outside the bezel, I used the Miracle 12 and the guide wire. I could advance a little by little with good resistance. And in this point, I delivered the string-length LP balloon and perform the stroke technique at the same time to decrease the hematoma, and I stick a true lumen with CP12 still like this, and then after that the swap with the XTL into the true XTL could be successful into the true lumen like this, and to check the entry of the double CTO with the checking with the tip injection, and I confirm the double CTO like this. And next, I use the next to penetrate the entry, and the escalation strategy. With the escalation strategy, I change the next one and catch up the two lumen like this, and the 3 DES was deployed like this, and this is a final angiogram. Good impression, good procedure. The second case, with Ibis Guidance. This Ibis Guidance case is the RCA CTO, approximate RCA CTO like this, but there seems no interventional collateral source like this to read this procedure success. So I changed the anti-grade approach only. This is a bidirectional contrast with dual contrast. And I started with the next 3 to penetrate the entry, and their advance with the next 2 and the Miracle Nail 3 and the Sion Brack without go outside vessel to keep the distance and length, and change Ibis Guidance. And with Ibis Guidance, next 3 to the CP12SD. Now CP12SD could penetrate the a hard plug, and with deflection effect, the guide wire that could advance a little by little and cross to the true lumen like this to check the dual contrast. And in this situation, the mini extreme stretch small balloon was delivered, but the delay and the sufficiently could not be advanced, and change the Zinlight 0.75 mm mini balloon could deliver and enough expansion, get enough expansion. And checking the Ibis, I confirmed the true lumen along here, and from the true lumen to the false lumen, Zinlight 2.5 mm big balloon was delivered, could be delivered and dilated on here, and I could deliver the easily Ibis. And with Ibis Guidance, I use the CP12LC in this point. With Ibis Guidance, with coaxial Ibis Guidance, like this, very close to the true lumen. The more close to the two lumens are like this with Ibis Guidance. And finally, it's successful to penetrate the hard plug into the two lumen like this with the CP12 with wide deflection. And the mini balloon was delivered, and the 3 stent was deployed, and the procedure was successful and good deflection like this. To last the how to use the CP12 yes, be careful to use it by understanding its penetration force. In this case, there's a little trouble after penetrating this huge calcified nodule with CP12 As you can see, there continued tortures and diffuse lesion to the distal RCA. CP12 might advance into the fourth lumen or the outside the vessel. The point would be issued for the future. Last, it's my take-home message for you. First, generally, when CP12 is not able to penetrate a target such as severe calcified lesion, the use of CP12 should be recommended. Maybe in terms of CTO strategy, it is favorable to use the CP12 from the beginning under the coaxial Ibis Guidance besides ADL. Third, the CP12 should not be used for retrograde wiring due to high risk of perforation. The last message. The CTO option and strategy using the CP12 might make room for further improvement and help in the present CTO PCF field. Thank you for your attention.
Thank you, Dr. Matsuda, for a nice introduction on this new wire. It seems like this is a version of a newer Conquest Pro, which had a sharpened tip. So the penetration force is higher, and also these characteristics can be reflected by the tough and complex cases that you have shown. Okay, so thank you for a nice lecture. Let me introduce our next speaker, Dr. Takeshi Nizeki from Okitama Public General Hospital. So today his topic would be a new transradial A-French approach for CTO and DCA. Thank you. Please, Takeshi.
It is an honor to have this precious opportunity today. I'd like to talk about the new transradial A-French approach to CTO and DCA. One of the obstacles of DCA is A-French femoral approach. New DCA ATOLCAT is 7 French compatible. However, it is difficult to monitor blood pressure accurately during the DCA procedure in 7 French system. In addition, because manipulation of guiding catheter is restricted in using 7 French guiding catheter, then 8 French system is preferable for DCA. Therefore, 8 French guiding catheter sheathless approach was produced from the concept of how to adapt DCA to a radial approach. The sheath is a very important system in PCI. However, a sheathless system allows for 2 French downsizing. Therefore, 8 French guiding catheter sheathless system can be set to be a virtual 6 French system. It is important to check the diameter of radial artery by echo before the procedure. In addition, Nicolangeal is helpful for prevention of spasm during the procedure. It is my basic system. We use 125 centimeter inner catheter to reduce the gap between 8 French guiding catheter and 0.035 guide wire. This is a comparison of the outer diameter and inner diameter of the sheath and guiding catheter. As I said, if 6 French sheaths can be inserted without any resistance, 8 French guiding catheter is considered to be insertable. We started the DCA by TRA from September 2020. All cases have been successful without any troubles. Recently, we are basically doing DCA from radial. These are the first 5 consecutive cases that were performed DCA by TRA. Initially, I think it would be a good idea to start with these simple proximal LED lesions because elaborate guiding catheter control is not necessary. I'll show one case. He is 75 years old. He was admitted to our hospital with a heart failure, complicated pneumonia. As his information are shown here. This is electrocardiogram and chest X-ray in admission. Laboratory data showed elevated troponin and BNP levels, and his renal function was normal. Echocardiography showed severe hypokinesis in anterior wall. Because RI showed ischemia of the anterior wall area, we performed coronary angiography on the 20th day after the admission. This is areocaudal view and areocranial view. As you can see, there is a severe stenosis at just proximal LED part. This is areocranial and spider view. There was no significant stenosis in the right coronary artery. This is the list of devices we used in this case. This is Ibis image. As you can see, the diagonal branch is here, and septal branch is here. And this is moderate lesion, like this point. And this is culprit LED proximal lesion. And LCX coming like this. The culprit lesion was basically circumferential concentric lesion. So I performed DCA by TRA in paying attention to the misalignment in the long axis direction, like this. We were able to achieve a percent plaque area was less than 55% by Ibis examination. We finished by DCB. This is final angiography. This is the actual procedure. After insertion of 6 French sheaths, we exchange using a 260 centimeter 0.035 guide wire from 6 French sheaths to 8 French sheathless guiding catheter system. Because the inner catheter tapers down to the 0.035 guide wire, so easily inserted on the wire into the radial artery. The tips of the 8 French guiding catheter can follow easily during open the skin entry site with the surgical blade, like this. And another chips is wetting the surface of the guiding catheter and inserting while screwing are important chips. The following procedure can be performed as usual, like this. Therefore, I came to the consider it may be possible to perform DCA and complex CTO lesions by using the 8 French guiding catheter sheathless system. The above paper is about CTO patients treated with the radial approach. The rate of puncture site complications were very low, less than 1%. The following paper is a study using sheathless guiding catheter. This study reported that not only higher patient satisfaction, but also fewer bleeding complications leads to the reduced mortality. This is a study using the 7.5 French sheathless guiding catheter produced by Asahi Intake. It has been reported that both complex stenting for left main stenting, left main lesions, and 2 mm rotor procedure can be performed without any problems while monitoring accurate blood pressure. A report about CTO PCI using 8 French guiding catheter sheathless was published in American Journal of Cardiology in 2016. In this paper, the success rate was comparable to transfemoral approach, and the procedure time and contrast volume were also comparable. As expected, the incidence of bleeding complications at the puncture site is significantly lower, and the 8 French guiding catheter sheathless system was reported to be a safe and effective method for CTO lesions as well. This is a systematic review and meta-analysis regarding the efficacy and safety of transradial and transfemoral approach in treatment of coronary CTO reported in 2020. In this paper, the transradial approach was much lower complication rate at the puncture site, as well as a higher success rate compared to the transfemoral approach. We'd like to show a case of RCA CTO by Toyohashi Heart Center. This is a simultaneous angiography. Approach site were bilateral radial approach, and the antegrade approach guiding catheter was 8 French short-term +1. XTR passed into the 4PL direction successfully. However, XTR seemed to be a shortcut in the angiographic finding. They used anchor technique to deliver Ibis catheter. 8 French guiding catheter was very stable and helpful for complex technique like this. According to Ibis finding, there seemed to be thin septum between 4PD and 4PL. Then they performed wiring using DLC, and Neo3 successfully got the 4PD. After protecting side branch, they confirmed wire position by Ibis. This is final angiography. Like this case, there are CTO cases that require the Ibis examination with anchor technique. 8 French sheathless system may be useful for these patients. However, in this report on 7 French sheathless guiding catheter, radial artery occlusion occurred in 6 out of 116 cases. So we should keep in mind about the risk of RAO. There are a lot of examinations about RAO all over the world. In recent years, the incidence of RAO has gradually decreased and is reported to be around 5%. there are many reports about the risk factors for RAO. The advantage of sheathless system is that we can use larger diameter of guiding catheter by TRA. However, it is still controversial whether the sheathless system is really gentle to the puncture site or not. In fact, there was a case report that glide slender sheath was broken like this. Then the puncture site is expected to be stressed by catheter manipulation in 8 French sheathless guiding catheter system. The demerits of sheathless system are mild hematoma occurs when changing the guiding catheter and reduced operability and the support of guiding catheter is lower compared with usual sheath system. Dr. Tsuchikane has started a new study to examine these issues. The purpose of this study is to examine the safety and usefulness of 8 French sheathless guiding catheter system. Inclusion criteria is shown here. Primary endpoints and secondary endpoints are shown here. I will let you know when I get the final result. Then please look forward to the results. Thank you for your attention.
Thank you, Dr. Nizeki, for a nice introduction of this new technique, the sheathless A-French intervention as an access. I think we do have a few minutes for discussion. Eugene, correct?
Yeah, yes, I think a few minutes.
Yeah. So Carl, Professor Yang, Guofeng Yu, Professor Lee, and Dr. Nakamatsu, do you have any comments on the 3 topic or talks we just heard?
Let me ask Dr. Eugene. So what is the most impressive difference in your new global algorithm compared to AP or Japanese algorithm?
So thank you for the question. I think there are 2 main things I would like to say is big differences. First, I think is the concept of anatomy dictate strategy. So all the previous algorithms have been quite mechanical previously and haven't adjusted to the anatomy of the CTO. So you can see in this algorithm, we use anatomy to dictate strategy and not a fixed strategy for all CTOs. And the second big difference is really this is not for the expert. This is really written as an algorithm for the everyday CTO operator in their own cath lab. So we allow them to stop if they have a minor perforation or if they're feeling tired or if the patient's feeling tired. So it's much more practical. And it's not like, I think the previous algorithms were all written by super experts and they thought about it as doing it in a live case where they cannot fail. So this is written much more for the average CTO operator. So I think those are the 2 biggest differences.
Well, Eugene, can you tell us, because I can see there is a minor modification from the previous algorithm, which is the limitation on the contrast usage. In the past, it was said to be 3.5 or 3.7 times of the GFR. And in this new global, it was reduced to 3. Do you have any new recent data or evidence to suggest or confirm this modification?
Oh, so the problem with this is that the data only exists in a very small subgroup. So the data for 3 comes from a study that shows the smaller group of diabetics, elderly female patients tend to get into trouble even with 3. We did argue for a long time whether we should specify that in the algorithm and say select subgroup of patients should have a cut down on 3. But in the end, we kind of decided it's difficult for people to grasp so many different things. So let's stick with 1 number. And we start with a lower number. Again, I think the paper is very focused on safety. It's not for the expert who's doing a live case who needs to succeed. It's for the everyday operator to keep him safe. And that's why I think the safety paper, which is coming out, and you've seen it already, of course, is a very important companion.
Yeah. Always patient come first. Safety first, yes. unfortunately, Dr. Matsuda cannot be with us at this time, so we cannot discuss too much about the CP12ST with him. But Dr. Nizeki, do you have also some experience with this new wire? Can we also discuss with you?
I'm sorry, I have not used a new CP12 ST. I'm sorry.
I see.
Yeah.
Actually, I have had some experience with it because I've had the batch of a CP12ST, and actually Carl has used it too. The problem is sometimes it's quite easy to puncture things with this, including the microcatheter and the Stingray balloon. So you need to really watch it coming out, especially if it's going around a bend. And in my practice, I find it's rare to need to use it because you usually only use it after the CP12 hasn't gone, and most of the time after good backup and anchoring. So I still have 3 more, I think, in my cupboard that I haven't used yet. So rarely used, but you got to watch it when it goes round in a microcatheter or in a Stingray balloon, that it doesn't.
Right. Dr. Nakamatsu, do you have anything to add?
Okay, and that focus on the CP12ST, is right?
Yes.
Okay, and unfortunately, this new this guide was quite new one. Unfortunately, I don't have experience using that. But I hear about Dr. Tsuchikane. So basically, this Conquest Pro 12 ST is basically the concept is for using the ADR. And so as you know, this ADR we need more big angle and a big sort of lengths, the longer lengths for tip curve. So actually, this CP12 ST have the 1.3 millimeter length, and usually we have the pre-shape just on the 1.0, a little bit long, a little bit long, and the angle is a little bit more big angle, and compared with another pre-shape one. So, and the Dr. Tsuchikane they make the samples and for avoiding the over the wire lumen, the maximally the 1.3 and the maximally the 45-degree angle is there, maybe avoiding the breaking this over the wire lumen and the Stingray. This is the concept.
Okay, thank you.
Yeah.
Dr. Nizeki, can you comment quickly on the discomfort of patients using this system? I mean, when you exchange the 6 French sheath to a sheathless 8 French guide, what are the expected discomfort from the patient, or none?
Yes. If inserting the 8 French guiding catheter system without any resistance, exchanging from 6 French usual sheath to 8 French guiding catheter is usually available.
I have one question. Dr. Takeshi, you tell us that the success rate of sheathless radial approach is higher compared to femoral. I don't understand. Can you explain?
I'm sorry. I have accurate data compared to success rate between radial approach and femoral approach. However, recently, success rate of TRA is very higher, like transfemoral approach. So we would like to investigate the success rate of 8 French guiding catheter system with Dr. Tsuchikane in the future. Thank you very much. Yes.
Thank you.
I have a question, Dr. I want to ask, will you avoid using a shiftless approach when you encounter very tortuous vagus artery at the shoulder? So, I mean, if you encounter these kind of tortuous vessel, what are your advice for us to do this shiftless technique? Is there any tricks that we can help us to sit the guide?
Fortunately, I have not encountered the anomaly or toxicity of from radial and brachial artery. So I could success this system. However, of course, as you concern, there are some anomaly or toxicity from radial artery to brachial artery. This system is not favorable. So we have to consider another puncture site or another puncture site. Yes.
Okay.
So
Thank you.
maybe we should move on because
Yes,
we're running a
Eugene,
little
please.
bit behind. So thank
Yeah.
you, Paul, for taking care of the first half. So next we have a recorded live case from Cao Ziyun Chan from Hong Kong. His center now is the Hong Kong Adventist Hospital. He's the APCO Club Fellow in Hong Kong, and he's worked with me for about a decade, I think, together at the Prince of Wales Hospital. So please, Cao, show your case for us.
So my patient is 76 years old gentleman, got history of hypertension, hyperlipidemia. He was admitted with pneumonia and non-ST elevation MI required ICU care. On admission, it showed that there is a dynamic troponin rise with dynamic ECG changes over the anterior lead. Echocardiogram showed ejection fraction of 60% with mild hypokinesia over the inferior wall. Coronary angiogram was performed. It showed a distal left main disease and also proximal to distal LAD tight lesion with a subtotal occlusion and the ramus, together with distal RCA CTO. PCI to the culprit vessels was performed in the same admission, and the patient was then referred to us for RCA CTO PCI. Here is the coronary angiogram after the stenting into left coronary vessels. You can see that there is a collateral supply to the distal RCA, and the RCA angiogram will show that there is a tight mid-RCA lesion with totally occluded distal RCA. So here comes to our recorded live case. We start our case with one radial axis and one femoral axis. For the left side guides, we use a 7 French XB40 guiding, while for the right side guide, we use a RB1 7 French guide. So here's come to our live case recording. And you can see that there are some collateral branches from the septal, but at the end, it looks very tortuous. So since from the RCA angiogram, there is some proximal cap ambiguity, you can see there is some staining there. So because of this, I would like to ask the panel, do you have any recommendation for me when I encounter this kind of proximal cap? So can we ask the panels to have any recommendation? How should we approach this lesion?
From here, it looks like there could be some microconnections or microchannels. So I would start with integrated probing with something like STA. Mm-hmm. Of course, not too aggressive because we are facing with bifurcation distally. There are multiple retrograde options. So like I said, I will start with the integrated probing with the XTA, and then maybe switch back to retrograde very quickly.
So indeed, I try to use the workhorse wire, make sure that there is not much channel from the proximal cap. But when I try to manipulate the wire, it seems that I encounter a lot of resistance there. So I just did what Paul suggests. I use XTA, hydrophilic coated wire, supported with caravel wire. So you can see that the XTA was able to advance further.
But at this point, where the wire stopped, I felt a lot of resistance there. So at that juncture, I think that I should advance my microcatheter to increase the torque control and to support the wire. But unfortunately, my caravel microcatheter doesn't cross at the band. So I have to trap it out and then use a small balloon, Sapphire 3 1.0 balloon. And you can see that there is a lot of resistance there. Is there any suggestion from the panels when you encounter such kind of scenario?
So, Dr. Nakamutsu, would you be going retrograde at this point, or would you still keep antigrade? And what would you do?
Thank you very much. And it looks like actually a very tough case from the antigrade because of the title stenosis, and seems like some clarification. And there's already there poll that say that actually this CTO exit part is a phase 2 their bifurcation. And we can see there are a good quarter channel there from the J channel score is a intermediate category, is an intervention one. Yes, and in this time I would like to switch to the later grade.
That's good.
Well, it's obvious that guide support is not enough for these micro. So I think even though you are using M plots, maybe we should look for these side branches for anchor to stabilize the system. You see. Wow.
Yeah. So what I did, thanks, Paul. I totally agree with you that the guide support is not that good. So in fact, when I try to push in my guide, there's a lot of hypotension there. So what I did is that I have to downsize my RB1 guiding to AL.75 guiding. So at that juncture, in my thinking is that I have to have some sort of proximal cap preparation before I go to the retrograde. So since seems that there is some mid-RCA lesion, I designed to try to open up the mid-RCA lesion. I think that I can get my trap liner into mid-RCA to improve the support, so that when I go to the retrograde, I may have a better position to have a reverse cut there. So at that juncture, I downsized my guiding to AL.75 guiding because there's a lot of pressure, the AR induced by the RB1 when I push in the guide. But after that, because the guiding is much better, as spotted by Paul, I switched to, with the trap liner support, I switched to the turnpipe spiral microcatheter supported by the same wire. The turnpipe spiral microcatheter was able to get forward beyond that lesions. So may I ask for the panel, for the advice, at that point, will you go to the retrograde right here, or will you try some antigrade wire manipulations? So this is the closer look of the retrograde angiogram. So it seems
it's a bit tempting, isn't it? It's quite near.
It seems that it's very short from my wire tip. So that's why I have a brief try with the UB3 wire.
Why UB3? Why UB3? I just want to ask the panel, why escalation? So why UB3 versus Gaia series? What is your strategy or philosophy behind this change?
So for me, I think there is some cost concern because UB3 is a cheaper wire. At that juncture, I was thinking that I would like to have a more torque control wire. So that's why I picked UB3. So is there any comment from other panels? What kind of wire would you use?
It looks like still there's a microchannel connection. So if the XDR is not working, I move to XDA, new one.
So in fact, the UBV doesn't work. So I want to step up my wire with a more puncture power. So I switched to Gaia third guide wire. At that juncture, I don't have Gaia next third. But you can see that with the wire manipulation, the intramural hematoma is huge with some contrast staining. So is there any suggestion from the panels? What should I do next?
I think the hematoma is partly related to the manipulation of UB3.
Yeah.
Because with UB3, you have to torque it a lot. It's not that directional.
Yep.
And then you also inject antigradely. So that will also enlarge the hematoma.
Yep.
So like I said, maybe cost is a real issue. But for me, I will switch from XTA to Gaia directly and with minimal rotation and drilling movement. I will try to puncture correctly and track the soft tissue with Gaia with the minimal contrast injection from the antigrade. We should be injecting from the retro.
Okay.
That is fine.
Thank you, Paul.
Yeah.
So since there is a lot of hematoma there, so I go back to retrograde. So I try to wire the first septal with the cyan blue wire. Since the septal ostium has been covered by the stent previously, I'm not able to pass the crosshair pole at the septal os. So at that point, I tried to use a 1.5 balloon to dilate the septal os. And then able to get the crosshair pole into the septal. And the angiogram on the right is the selective angio from the septal. So you can see that my wire currently have a reasonable septal channel there. So I use the SUO03 to try to wire this septal channel. But there is some resistance for the first step. So I manipulate the SUO03 wires for around 7 minutes, but it seems that the SUO03 cannot get through that septal channel. So I try another another branch of the collateral.
Excuse me, I have one comment.
Yep.
Yeah, and this like the septal channel is actually have the many branches. Looks like a comet morphology, and so there maybe the dual lumen microcatheter is suitable for this like situation.
I see.
Yeah.
Thank you very much for your comment. So it seems that for this channel, there is some connection there. But at this wheel, I'm not able to get to the target septal channel. So what I did on the next shot is that I changed to another wheel to lay out the entry of that septals. It's going to come for the next entry. So I go to the aerial quarter wheel. It shows to me that the septal, the channel's ostium is bifurcate early. So I use this wheel to enter this target channel instead of manipulation in the aerial wheel. So it seems that my wire currently my target. But you can see that there is a almost 30 to 360 degree bend in the channel. So I have to advance my SUO03 wire further to straighten that band before I can advance the microcatheter. So these channels are able to get through with the SUO03. And the wires comes to the PLV. But you can see that there is a bend in the entry to the PBA. So when I try to advance the turnpipe LP microcatheter, it doesn't cross the band. Eugene, do you have any recommendation to me at this point?
Well, so you know the APCTO algorithm always says if you can't cross in the retrograde algorithm, you should change catheters. And I think today is true. Microcatheters are so much better nowadays that usually if you change another microcatheter, it will work. Especially if you try pushing the first microcatheter through stent struts, because that tends to damage the tip. So I think the first line now should be a change of microcatheter. One of the options is to change a short, bigger size catheter, such as traditional Corsair Pro, and that will give you more torque and drill the hole and then replace it then with a thin microcatheter. That would also work, I think.
Is there any advice from other panels?
Yeah, I think a short version of Corsair Pro would have some bugination effect on the proximal channels. And then even though the 135 sometimes won't reach the distal, but after the bugination, you can switch back to the 150 that you have been using. And then suddenly you will be amazed by how easily it will be delivered.
In fact, I do exactly the same what Eugene and Paul suggest. I use the 135 Corsair Pro. So you can see that the Corsair Pro was able to get through this band with a lot of rotation of the microcatheter. So this is, I think this is the most distal, the farthest location that I can achieve with the short Corsair Pro. So when I back it out, you can see that the guiding suck in quite a bit. So I have to control the guide. So I try to save costs, use the same turnpipe LP, the long version. But you can see that just like what Eugene said, because the catheter tip has been damaged by the stent strut. So despite I dilate the channel with the short version of Corsair Pro, the turnpipe LP doesn't go too far from previous, just a tiny advancement. So what should I do next?
You still have a caravel, right?
Yeah.
Oh, but it's already in
Yeah.
RCA. Yeah.
In fact, Paul already predict what I do. I pull up the long caravan. May I ask whether when will you choose a short corset pole to dilate the channel versus balloon dilatation to the separate channel? May I ask for the panelists' opinions?
So for me, I think the balloon would be later. I would usually try a microcatheter first. Maybe ask Yang-Su. Yang-Su, what's your experience? If you can't cross, do you go to balloon or do you go to big microcatheter or do you change microcatheter?
In my case, if there's a tortuosity as well as the small size of the channel, then I choose the balloon. But if there's only the small size of channel, I use the short corsair as a bugination effect.
Okay, good. Anatomy dictates strategy.
And so we have another approach, the ankle ballooning at the retrograde side.
But when we use the anchoring balloon technique, what are the tips and tricks? What should we do as the operator to have to watch out when we use that technique? Will that be too strong?
Yeah, very strong. Yeah.
So indeed, when we use the long caravel, it's just go through that channel very easily. So I'm able to go to the distal cap of the CTO. So in this case, what kind of wire do you suggest me to use?
Maybe we ask the panelists. Dr. Koo, what would your wire be if you were going retrograde?
For me, I think the microcatheter now is not in another position as compared with any grade, so I will maybe use the Gaia 1 or Gaia 2 wire in current retrograde approach, because I think actually the tip of the antegrade and the retrograde microcatheter is not in the same plane. I think maybe retrograde we don't need a stiff wire, we can pass it, but we need more toggable wire to pass by retrograde. So I think maybe Gaia 1 or Gaia 2 is my choice at this time.
Thank you, Dr. Koo. I use UB3. The reason behind is that I totally agree with you that I think the retrograde wire may be more intra-plug. So I try to use UB3 to hoping that I may have able to penetrate the CTO body with retrograde wire escalation. So I think at that point I packed my antegrade microcatheter attached because there's a lot of overlapping there because I can't see the wire tip very well. Yep. And then I try to use the UBV wire to try to penetrate the CTO body with the help of the antegrade wire as a marker. So at that point, you can see that my wire jump a bit. I feel that my wires puncture into, something, the wire tip feel is very free to me. I'm thinking that maybe my UPV wires puncture into true lumen. So that's why I try to back my microcatheter a touch, try to see whether I can wire through if this is in the true lumen, I may be able to get a bit RCA. But unfortunately, I encounter some resistance there. This is the point that where the previous caravel cannot cross, where the Sapphire 1.0 millimeter balloon cannot cross. If you remember this engine. So what should I do? Yeah.
I think reverse card for sure.
Yeah, and
But he said that
the
1.5 balloon cannot pass by integrate, right?
Yeah.
and
So
we
even
have
1.5 you cannot pass. Or
At the
if we
one,
use Telecaster, where you have a better support by integrate.
I'm sorry.
If we use a Telecaster in such kind of case, now by retro integrate, where it have a better support, if we use a Telecaster, and then maybe 1.5 can pass sometimes.
I see.
yeah active grading. Yeah.
So at that point, because I truly believe that my distal wire maybe have segment of true lumen, but I cannot confirm it. So at that point, I was just thinking that maybe I advance my retrograde caravel to the retrograde wire tip may improve the torque control and also the penetration power. But when I try to advance my retrograde caravel, it doesn't cross the CTO body. So is there any suggestion that I should overcome that?
I think you should not advance your retrograde catheter too much beyond this point, because the wire tip is too short to give you any support. So you should work hard on the integrate system to improve support and deliver your balloons more distally. And you did something like you have just did. It's reverse card.
So Paul, just say what I just did. I mean, I have cut a lot, some video. I mean, in fact, I used the track liner to support my 2.0 balloon, so that my 2.0 balloon can advance beyond that resistant part. So in fact, the previous angle is that I try to track my retrograde wire with the 2.0 balloon, and then try to drag my retrograde caravel to advance into the CTO body at touch. With the help of this anchor, the retrograde caravel can advance beyond that CTO body. So then at this point, I try to do the reverse part with 2.0 balloon. But when I try to advance the UB3, I feel a lot of resistance beyond the mid-outskate, right at the retrograde wire tip here in the current the forward image. I cannot advance further beyond this point. I mean the resistance point, where the previous 1.0 balloon cannot cross. So what should I do? So I pull up my Ibis to check what's going on. So you can see that two wire, one is retrograde wire, one is the antigrade wire. At this point, is two wires in the true lumen. But right at the mid RCA at the resistance points, you can see here, the retrograde wire goes to the false lumen again. So with the help of the Ibis, I know that where the two wires connect. So my strategy changed with the help of the Ibis. I try to drag my trap liner to the position where two wires has connect in the retrograde in the true lumen. Then I switch to Xeon black wire. The idea is that I think that it's more hydrophilic coating wire without much penetration power, so that my retrograde wire won't go into that subintimal space again. So here is slip through the subintimal space. So I changed to another wave to help me to direct my Xeon black wire, since I already confirmed that there is connection made by the UP3.
Excuse me, this is a Telecaster or a triple balloon?
I'm sorry?
This is a Telecaster or?
It's a Telecaster. It's a trap liner.
This trap line.
Yeah. Trap line.
Telecaster with a trap balloon.
Yeah.
So you can see that my Xeon black wires is right into the Telecaster.
Yes.
So able to make connection from retrograde to antigrade. But indeed, my story doesn't end here. So the rest.
I can see, Carl, you are working with a magnified field.
Yeah.
So
in order to save radiation.
Well, that is contrary to what the fact is. You know, in fact, if you don't make up, you will have less dose.
Because yeah, you're right. Yeah.
And because you now are making up, so you cannot see the whole retrograde tract completely throughout the procedure. So with all this struggling, sometimes the septal will be damaged, and the microcatheter will prolapse into an apical direction.
Mm-hmm.
Yeah, with a make-up view, you cannot appreciate that early on.
Yep. Oh, so thank you, boss, for the comment. So I missed up that Ibis comment. So when I do the Ibis after externalization, so you can see that the Ibis from distal to proximal. So here the distal, you can see that there is a huge hematoma in the right in the bifurcation. It's the hematoma right here. This is the hematoma created by the wire manipulation. So then, so when we see the hematoma right at the PDA bifurcation, so what should I do? Is there any suggestions? Should I just stand all the way into the PDA, or I try to stand the distal RCA first to see how it does?
Well, of course, you can load a dual lumen catheter on the externalized wire and then try to get into the PLA before you start any ballooning or stenting. Because by losing one of these distal branch, I won't call this procedure a success.
Yes. This is a huge hematoma, though. I think I would be thinking about straw. It looks huge on the.
So in fact, at that juncture, the reason I haven't used a pause advice is that I think that if I try to load the stand without the externalization wire, I may not be able to get the stand to the distal RCA because of resistance. When I try to...
Not a stent, I mean a dual lumen catheter.
Yeah.
So you wire into the PLA before you deliver the stent.
Yes.
So I still load the stent into the externalization wire, right?
Yeah. Mm.
So at that point, I haven't done the ways that you suggest. Yeah, maybe next time I should. So I stand the proximal to the distal RCA before the bifurcations. Because at that juncture, I'm just thinking that, oh, could we take it up the dissection entry? Maybe the hematoma doesn't expand. So this is after stenting, you can see that I lost the PLV branch. So I use the double lumen microcatheter to help me to wire to the PLV. So I should have it done before the stent. And
I'm sorry that after that point, my phone is out of battery. So what we have done is that we removed the retrograde microcatheter and to have a channel check. You can see that there is no channel injury. So after that, we performed a predilatation to the PLV branch with a 225 balloon, and then we perform an Ibis check to the PLV. This is the distal landing zone, and you can see that in the PLV bifurcation, there is a huge hematoma compressing to the true lumen. And after that, we performed DES stenting to the PLV branch with a 225 by 38 stent, and then this is the final angio after the post-dilatation. Initially, I want to wire the PDA branch. However, the patient is struggling a lot since there is a TIMI free flow, so I decided to stop here. And I hope you enjoyed this recorded live case. Thank you very much.
so this come to the end of my videos.
Thank you, Carl. And we've got 2 minutes of time, so we are a little bit okay. I think that it's very difficult to deal with distal hematoma in a vessel like this. So ask Dr. Lee, what would you do if you see this huge hematoma on the Ibis?
First, we check the distal landing zone, and if the stenting the normal looking zone, I think the hematoma will subside.
So just like Carl, anybody has another opinion with dealing with this kind of hematoma?
Yeah, we had option using the cutting balloon. Sometimes have a good effect. Yeah.
I will also use cutting balloon because I can maybe have a better shorter stance. Yeah.
May I ask, when you use the cutting balloon, how would you size? So you size it with the distal reference, or you judge it by the hematoma size?
I would do by according to the Ibis finding. The compressed true lumen, maybe a little bigger than the true lumen. So just by Ibis, I will decide the size of the cutting balloon and then do the cutting. Yeah, but I need to wire both branches.
And so for this case, the Schoenbrock guide wire and for the reverse cutter is a very nice performance. And as you know, that when we perform the active grading technique, already created their dissection at the CT lesion at the proximal part of the CTO. When the B and the B for your procedure, you use a more harder wire. I mean, very easy to get advanced to the proximal part of subintimal space. I would recommend it more a softer guide wire for the active grading technique. Thank you.
Okay, so we've come almost to the end of our session. Are there any last comments? If there's not, I will close the session here. I want to thank all the panelists and the presenters, and of course my co-moderator, Dr. Paul Gao. It's very good to see you all, guys, and thank you for joining this session. Thank you very much.
Okay.
Bye-bye.
Thank you very much.
Thank you.
Thank you.
Bye bye.
Bye bye.
Thank you.
Bye-bye.
Bye-bye.
Thank you.